For overview, we'll be looking at the equipment setup, medications, review our checklist update, and then we'll do an RSI procedure and some RSI Pearls. I like to divide the RSI equipment into two phases, the preparation and the pre-induction phases. The reason why I do this is once you have the preparation phase complete, you can slow down and you'll have time to complete the pre-induction phase. Now let's review the two phases. For the equipment preparation phase, you want to get this set up quickly. Once you have this phase set up, there are very few situations in which you won't be able to manage the patient's airway if they decompensate. So you want to get the checklist out. Checklist is the most important tool to a successful RSI. You need to position the patient, ear to sternal notch, have both the regular and end-tidal cannulas out and on, BVM with PEEP and end-tidal prepped, have a rescue device ready, in this case iGel, and have suction on and behind the patient's right shoulder. All right, pull BVM. Okay, ear, sternal notch, perfect. Okay. Got my regular cannula out. Okay, Stats 99 still. Ready?
Okay. Yep.
Pull. Okay, back on. Okay, Stats 99. Ready?
Mm-hmm.
Pull. Back on. Perfect. Sats still 99. Okay. There's iGel. Last thing to do is get the suction ready, okay?
Okay.
So I'll take over bagging and then just get it on, turn on, and I want you stuff under his right shoulder.
Okay.
All right? Ready?
Yes.
All right, I have it.
Suction's on and under his right shoulder.
Okay, take that out.
Got it.
For the equipment pre-induction phase, these are the items that are specific to the intubation. So have the King Vision on, tested by the left shoulder, having your primary tube out with a Regis eyelet near the right shoulder, having your backup tube ready and your backup blade ready, having your tube securing device, your OG-NG tube out and measured with the 60cc syringe, and your cric kit. We need to switch spots so I can get ready for RSI.
Okay.
You okay there?
Yes.
All right. So checklist. Next is King Vision. On. Green light. Okay, turn it back off. Place next to the left shoulder. Next is my tubes. So I'm going to use an 8.0 King Vision stylet and a True Cuff. Pull about 4 mils into it. Next to the right shoulder. My backup blade and bougie. Backup blade. Bougie. Tube holder. Thomas to the top. Okay, what I'm going to have you do is I'm going to have you remove the BVM.
Okay.
Go. Okay. OG-NG. Alright. 60cc, 40 mLs, connected already. Xiphoid process around the ear, to about tip of the nose. Okay, need to mark it. Sharpie. Okay. Coil out of the way. All right. And now cry kit. For medications, I'm going to highlight two of the most common packages you'll use. Ketamine and rock, or ketamine fentanyl rock. The addition of fentanyl is about controlling ICP. So this is real easy. If you think the patient has a brain problem, whether it's an injury or a stroke, or you're not sure, you're going to add fentanyl. The dosing is extremely easy now. We're going to do 2 milligrams per kilogram of ketamine, 2 micrograms per kilogram of fentanyl, and 2 milligrams per kilogram of rocuronium. Let's do an example. You have a 100 kilogram patient that has an isolated head injury from a bat. Which package would we choose? The one with fentanyl. So we're going to do the ketamine fentanyl rock package. Math is really easy. The patient's 100 kilograms, everything's times 2. So the dosage is all the same. 200 of ketamine, 200 of fentanyl, and 200 of rocuronium. All of the dosages have been updated in the PPP app, are now live in our guidelines. Next, for medication, what we have here is we have push dose epi. Then for the induction, we have fentanyl, ketamine, and rock. And on the left-hand side here are the post medications. We tape them together and, if possible, change the color on the syringes so that we don't accidentally administer those medications during the induction phase. Also, each one of the syringes for the induction medications are in different size syringes. Typically the rock's the most, so it's 20, and then ketamine is the most concentrated, so it's the smallest, in a 5, and the fentanyl in a 10. We've updated the checklist to mirror the education. Let's go through it. First, we want to get baseline vital signs, just to make sure that there are no reversible causes. Next, patient positioning. We need to put the patient into the ear to sternal nos position. We do this first because as we set up, we're going to be placing items around the patient, which makes it more difficult to move them later. For pre-oxygenation, we want to do 2 MPAs, then a regular cannula at 15 liters a minute with the end-tidal cannula on if they're breathing. If they're not breathing, we use the BVM with PEEP valve and end-tidal and assist respirations. For the preparation, this is just the remaining items that we need to have set up. So IV IO access, having the eye gel out, suction on, ready behind the right shoulder, King Vision with a rigid stylet, your primary and backup tubes, whatever your direct scope choice is, with the bougie, 2-polar, your NG-OG tube with the 60cc syringe, and the cry kit. Next is the pre and post meds. I think about them together because if you just draw them at the same time, it's one less step you have to do after you have the tube. And when you do them together, it actually saves time. You already have the syringes out, you already have the medications there. It adds maybe 15 or 20 seconds to prepare the post meds. Next, we want to get our next vital sign set and set the monitor to Q5 if you haven't already done it for the pressures. And then it comes to induction. As we'll have our push dose epi ready, and then as we talked about in the medication section, we're either going to choose the ketamine rock package or the ketamine fentanyl rock package. For post intubation, we want to verify the tube with end-tidal and lung sounds. Lung sounds, yes, because you want to make sure there wasn't a change in lung sounds from the medication administration, such as pulmonary edema. We're going to give our post meds, and then prepare our post sedation drip. The backside of the checklist reveals the medication dosing. It's broken into 3 different categories: induction, post-intubation, and the maintenance. So the induction phase, obviously, is to get the tube. Right after we have the tube, we give the post-intubation medications. We do this because this allows us time to set up the maintenance drip. On the bottom here is a recommendation on how to mix the maintenance drip. Okay, it's been a minute since the rock. Jaw's totally relaxed. All right, so what we're going to do here is I'm going to pull the BVM. I want you to remove the end-tidal cannula.
Okay.
Then remove the mask from the BVM.
Okay.
And then you'll watch the SpO2, and I want you to yell out when it hits 93, okay?
Okay.
All right, next breath. Ready? Pull. Insert the kingfisher blade as far as I can see. Chase it with my suction. Okay, rotate to the screen. Airway's totally clear. Suction's out. Have a good view. Grab my tube. Insert just past the cords. All right, remove the stylet. Inflate. All right, BVM. We have end tidal. All right, tube secure. Let's go ahead and get vital signs.
Okay.
Hold this.
Okay, your vital signs are running.
All right, do that again. Confirm our OG tube. I have the back. Go. Okay, confirmed. Check our cuff pressure. All right, we're in the green. Let's review how to set up the post-sedation drip on the pump. Select EMS. Select channel A. And then we're going to hit page down until we can find ketamine. Takes one push for page down. Highlight ketamine. Click choose. It's supposed to be 500 milligrams in 500 mLs. Patient's weight, in our scenario, it's 100 kilograms. And for the dose, we'll be selecting 2 milligrams per kilogram per hour. However, the pump won't allow that for right now. It's coming in an update, so we'll select 1. And so it's going to deliver 100 mLs per hour, because it's 505. So deliver 100 milligrams per hour is 100 mLs. For volume to be infused, VTBI, we're going to select 450. We do that because we want it to give us a warning when it's running low so that we can make a new bag. We don't want it to be running out and have to start a new bag and a new plumb set because it's pulled air into the line. The last thing we'll talk about is the RSI Procedure Pearls. Pre-procedure planning. This means that you and your partner practice RSI setup regularly. If you do this, you'll be smooth and ultimately more successful with your RSIs. Next, checklist, checklist, checklist. This is the most important tool in RSI. Even very experienced providers will make errors because they did not use a checklist. Lastly, patient positioning and medication timing. If you do ear to sternal notch and wait for the medications to take effect, you'll get a 50% increase in your first attempt pass rate. This video is about the RSI procedure. This is not a replacement for an RSI class. There is much more to the procedure and the medications that we have to talk about. This is just a shortened version to help us get prepared and set up correctly. This concludes the RSI video.